Thank you for coming. I want to thank the sponsor, CathWorks, for helping us to put this symposium together. It's very important that we have these dedicated single treatment or single methodology symposia to really go deeply into understanding how some of these novel new techniques are being used. It's extremely important that there be a good interaction with the audience, so we really want you to participate as best as you can. And it's always a help to have outstanding faculty, which we certainly have for this meeting. This session is called CathWorks FFRangio, Proven Outcomes Without Compromise or Complications. I'm going to kick it off. And this is going to be just a 5-minute introduction. It's going to give you a sense as to kind of where we've been, just to frame some of the issues that you're going to be hearing about in much greater detail. So I think we've evolved in PCI. I must say, when I began in the 70s, 80s, 90s, we really talked about devices and we thought of ourselves as being proceduralists. I really think now that we talk about delivering therapies for patients with a disease, and we try to get back to the idea of being clinicians. So it means thinking about what you're doing, not simply reacting by using a device. Also means thinking beyond just the index procedure, but worrying a little bit about what happens before and after to the patient. I can tell you through the history of PCI, there's been a constant tension between several forces. We've brought what we thought was a less invasive technique, and we've always been compared to surgery. We struggle with the efficacy, safety, dynamic, and understanding if there's an acceptable compromise. The issue of simplicity is extremely important, certainly in many parts of the world. The French acronym of KISS, keep it simple, stupid, is something that people really believe is an essential component of PCI if it's going to be generalized. And also understanding complexity and whether or not complex technologies and complex procedures are truly better, and what is the value proposition. So there's no question over the past decade that physiology reigns supreme, and some of the people on the stage have really led that revolution. First, we added wire-based physiology that, yes, was invasive, and yes, to some people was a little bit complex, but the data, starting with FAME, was extremely impressive, and then it extended beyond, demonstrating that resting indices also can achieve an understanding of physiology's importance in terms of clinical outcomes. But the quest to achieve a more scientific PCI by integrating physiology guidance into routine clinical practice has still been a somewhat unrealized goal. There's no question that there's global underutilization of physiology as part of PCI. Generally, it's used in less than 10% of cases. And that the global variability in the acceptance of physiology determinants and guideline endorsement and reimbursement has been problematic. Part of this may be that wire-based physiology poses some limitations, and it's contributed to this underutilization. It increases procedural complications, maybe a little bit on the risk side, not much, but a little. Certainly procedural time, additional costs. The wire manipulation of many of the wires is not great, and complexity or issues with the measurement sometimes can be an issue. So we've attempted to simplify physiology using CT and now using angiography, which is now non-invasive, and that simplification makes a difference. By just looking at routine angiograms and incorporating comprehensive physiology with a CathWorks wireless AI-powered FFRangio system, really does change the way you think about applying this in everyday PCI. The adoption of disruptive medical innovation is complex. You have to go through an early phase where pioneers use it, and then you've got to build workflow, and then you've got to mainstream it. This usually takes about a decade, believe it or not. This is the pathway and adoption curve so far of FFRangio. Interestingly, it was discovered and founded in 2013. The initial FDA 510K clearance was in 2018. We did the FAST FFR study published in 2019. Japan got involved. We began developing global registry. We had AU MDR in 2024, and then in 2023 began the All Rise study, which we'll be talking about in various of the presentations, and completed enrollment in less than 2 years, which was beyond their expectations at the same time the Provision RCT was being done. So there's a lot more clinical evidence that we're accumulating with validation studies, the original FAST FFR study, looking in multi-vessel disease, real-world outcomes, and on and on. In total, about 4,000 patients have been involved in these clinical trials, resulting in a series, as you can see here, of 7 publications. And the global adoption has clearly expanded at the time that we've been accumulating these data, such that right now commercial adoption indicates that more than 75,000 patients have been treated with this technology. So CathWorks is more than just a technology. It's a little bit of a movement to transform the way we do PCI and transform patient care. And let the games begin.
So it's my pleasure to speak about seeing is believing, all the evidence that defines FFRangio and its rise to clinical validity. These are my disclosures. So as you've already heard from Marty, there's a wealth of robust data supporting the role of coronary physiology to guide PCI. Numerous randomized clinical trials have been published in a variety of patient settings, and this has resulted in a Class 1A indication for coronary physiology, FFR, or a non-hyperemic pressure ratio to assess intermediate disease, and a high-value cost statement associated with that. Yet, as you've also heard, coronary physiology continues to be underutilized, and there's probably a number of reasons. It can take extra time. There are issues with the wire handling characteristics, pressure drift, and other factors associated with the measurement can be frustrating. If you're measuring FFR, the side effects of adenosine, it's expensive, and there is a small risk anytime you put a wire in a vessel. And as you can see, all of these issues are related to the need for a coronary pressure wire as well as the use of a hyperemic agent like adenosine. And so that raises the question, well, what if we could get all of this information just with the angiogram alone and no need of a pressure wire or adenosine? And that's where angiography-derived physiology comes into play. Now, 6 years ago, we published these data comparing FFRangio to wire-based FFR in a blinded fashion, 10 centers, over 300 patients. And you see that there is a very high sensitivity, specificity, and accuracy, all above 90% with FFRangio. And what we found even more impressive was if you look at the gray zone or around the cut point of the FFR cutoff of 0.80, this is where most tests have an accuracy of 50%, kind of like a coin flip. You see that FFRangio continued to have excellent diagnostic characteristics in that gray zone area. We also looked at how FFRangio compares with the non-hyperemic pressure ratios with regard to its correlation with wire-based FFR. And you see that the accuracy of FFRangio is actually higher than the resting indices when compared with pressure wire-based FFR. So what clinical outcome data do we have to support angiography-derived physiology? Well, we have data from the FAVOR3 China study, which used the QFR system. This was a very large randomized study comparing QFR-guided PCI with FFR-guided using a pressure wire. And it showed a significant improvement in outcomes. But this is kind of a recapitulation of the FAME1 trial. We know that physiology is better than angiography alone. What we really want to know is how does FFRangio or angiography-derived physiology compare to wire-based physiology. So the QFR group also did the FAVOR3 Europe study looking at just that in 2,000 patients, where they compared QFR-guided with FFR-guided using a pressure wire, and they found that actually the pressure wire outperformed QFR in this study. And the question is, why did that happen? Well, one thing that they saw was that QFR led to significantly lower values compared to FFR, and this resulted in a significantly greater proportion of patients who underwent revascularization. So you could argue, well, they just got more stents, and so that's why they had a higher event rate. But an interesting sub-study looking at just those patients who had deferral of revascularization based on QFR or on FFR actually showed that there was still lower event rates in the FFR group, which suggests, well, maybe the QFR was also missing lesions that should have been stented. So when you ask why Favor 3 Europe was negative, I think there's a few potential explanations. The FFR group did actually do quite well, and maybe this was just bad luck for the QFR arm. The other issue is that the investigators and operators weren't blinded to treatment assignment, and so maybe the QFR guided group were managed differently in some way. And finally, and maybe most importantly, I think it's important to remember that these angiography-derived physiology systems are all distinct. They all have their own algorithm and each needs to be tested to show that it's effective. So what data do we have with FFRangio? Well, we have a real-world registry looking at the safety of deferring lesions in almost 900 patients and showing a very low event rate at 1 year in those patients where PCI was deferred based on FFRangio. So reassuring that you can safely defer if you get a negative FFRangio. And we also now have randomized clinical trial data from Japan, 400 patients in the Provision trial across 13 Japanese sites looking at intermediate lesions. The primary endpoint of this study was non-inferiority of revascularization rate of FFRangio compared with wire-based FFR. And the investigators met the primary endpoint. FFRangio was non-inferior and had a similar revascularization rate. They also saw a significantly lower radiation exposure, 20% reduction with FFRangio compared with wire-based. And they followed the patients now out to 1 year and have shown that major adverse cardiac events, both with and without procedural MI, were equivalent, and if not numerically lower, with the FFRangio group. So very reassuring data. So what's coming next? Well, we just completed earlier this year the All-Rise randomized clinical trial. This is a almost 2,000 patient study comparing FFRangio guided treatment with pressure wire guided treatment. You declared which lesions you were going to treat or assess, and then patients were randomized. And if randomized to the wire-based, you could do either FFR or a non-hyperemic pressure ratio and treat per the result. If they were randomized to FFRangio guided treatment, then they underwent that. The primary endpoint was 1 year assessment of major adverse cardiac events, death, MI, or clinically indicated revascularization with a non-inferiority design. And we are planning on completing this follow-up in December and quickly, hopefully, analyzing the data and hopefully presenting these at this coming ACC. This study was led by Dr. Leon as well as Dr. Kirtane, and we had an excellent and varied steering committee involved. The final point I'll make is that there's a lot of excitement about angiography-derived physiology. We recently convened a roundtable sponsored by Sky and have a sort of white paper or consensus document that will be coming out soon, giving you a nice overview of the field. Thank you for your attention.
So I'm going to be talking to you a little bit about what this technology actually is and what the proposition for having it is. I mean, Bill took you very nicely through what the data needs to be and where the data is at. But for me, I think very clinically, and I think one of the major attributes of this type of technology is that it helps solve problems like the one I'm about to show you. And so this is what I call the diagnostic cascade gone wrong. It's a neurologist who had some risk factors, had prior PCIs, and was really going to go for a colonoscopy. And somebody decided to put the patient on a treadmill, maybe because they were worried he was a neurologist. He went no ischemia, went 10 minutes, and he had some of these changes. And so for that, went to the cath lab. And so you might argue, did he really need to go to the cath lab? Did he need any of this stuff done? But he did. And this was the cath that was done. And it's not very angulated. It's not the best angiography. There's perhaps some proximate LAD disease here. The circ is moderate, diffuse. The right is more moderate and diffuse. And then there's this thing, which I won't really even talk about. It's just ridiculous. You should not do this with this type of catheter. And so the problem, though, is that there was a lot of hemming and hawing, and the cath report said maybe there's this left main, and the LAD is 30 to 40, and this is just diffuse stuff. He has prior stents. So he was actually referred to one of our CT surgeons, the head of our CT surgery program, to have a CABG consultation. And so he called me up, and said, you know, I looked at these films, he's astute, he's the head of our CT surgery department, he says, and I don't see a whole lot there. I really don't want to even do anything. Is there something you can do with that wire thing where you get some numbers and you basically tell them that everything's okay? Because that's really what we need to tell them. And so I said, yeah, I'm happy to do it. There's a risk of every procedure, but what I ended up doing is doing FFR of all 3 vessels, and everything was over 0.9, but it took 2 guides, it took 3 vessels with 3 rounds of adenosine, wires, and we deferred CABG, we deferred PCI, he's back to clinical practice in neurology, intensified medical therapy, and he's doing great. But I had to go through all these steps in order to get that information, and the question is why couldn't that information have just been gleaned the first time around when he had the angiogram? And so there's several reasons why physiology is underutilized. This is a modification of a slide that I've had before where I used to show a good friend and colleague of our, late colleague of our, Dimitri Karpaliotis, who we're actually going to be honoring in the main arena tomorrow. But I don't have Dimitri's picture anymore, but his wisdom is there. And there's sometimes when he just is like, what the heck is going on? And so most people don't utilize physiology for a number of reasons. They say, I know better whether it ought to be treated. I'm an experienced catheterizer and angiographer. In other words, I know better. The data are flawed because I know better. I don't believe the number because I know better. I just really want to treat this lesion. Maybe because you know better, or maybe just because that's just weird, but nonetheless, it's just, the bottom line is it's too painful and complicated to do physiology right now. And I hate to say this with like Bill and Alan here, because you know they've led this field, but you have class 1 guidelines, and just people don't do it that frequently because it is a pain to do. And it's also not without risk, putting up guides and wires and that kind of thing. We're in a training program, and I'm obviously responsible for the case, but I always worry a little bit that there's going to be a problem. And so could you get the same information with a system like CathWorks? Now, so this is the old system. It seems a little crazy, but the reason that I'm showing it is because actually in the old days when this system first came out and we were in the initial trial that Bill led in this regard, it did take a while to do. And so, but the point is that there's basic information. There's the angiogram that's from the C-arm. You take that information, you put it into a console, and with minimal manipulation, you can essentially compute values that allow you to determine the physiologic significance of the lesion just for my patient without having to do all those steps that I did. So how does it work? It takes a 2D angiogram and it constructs a 3D model. Remember, the heart's a 3-dimensional structure that's beating. And so you have to take good angiography, but if you do it right and in the correct views, you can reconstruct a 3D model. You can then calculate what the perhaps resistances might be along the vessels and then come up with a physiologic assessment. And so proof is in the pudding. You have to basically do the concept and then see if it works. And so first, you need good pictures. If you take terrible angiography and you never see a lesion, there's no system that's going to be able to discern whether that lesion is hemodynamically significant because the system's not going to see the lesion. So you do have to take good angiography to see what's going on. And that's one of the reasons why this system in particular insists on 3 views of the lesion. It would be far easier for any company to say, you only need 1 view and we're going to give you a number. But the problem is if you do that, you might not get good fidelity of your tracing, and so that's why this technology is insistent on doing 3 views. You have to pacify the vessels, you have to see them, not so much panning, and it makes you a better angiographer as a whole, but it's not that complicated. It uses artificial intelligence. So how does it use it? It has a huge database of a lot of angiograms that are in the console's memory that allows it to figure out what's the LAD, what's the circumflex, what's left dominant, what the flow should be like in all of those circumstances. And so it breaks down complex angiograms into these nodes that allow you to figure out what's happening. Before the use of the AI, you actually had to draw every vessel. And when we were in that initial validation trial, I admit freely that I thought it was kind of cool, but I said I'm never going to use this in clinical practice with that system because I had to literally draw every single vessel. But what's changed between then and now, and that was several years ago, is now the AI allows the vessels to be sorted out, segmented, and even drawn up front. I've actually played with the new system and tried to re-edit them, and you can do that, but you don't need to do it for the vast majority of cases as long as you take good angiograms. So before you needed a lot of steps, the actual time to run this case that's fast forwarded here was 21 minutes, obviously unacceptable in the cath lab because we like to move fast, but that was because it was all manual. Now, what ends up happening is the angiograms are already segmented into the views. It sort of suggests which ones to take. You just pick which vessel it is, you enter in your blood pressure, and then you go forward. And I would encourage anybody that's in the cath lab, you need to know the jobs of everybody else in the room. So you should do these analyses yourself first to understand exactly what's happening, what's the limitations, what are the benefits, when you shouldn't use it, and then you can trust others to do it. And so at this point, what I end up doing is I'll take the diagnostic angiogram, and then I'll actually answer a couple calls, and then the lesion is there. And sometimes if I shoot the right first, because I'm a radialist, and then go to the left, if I want the right to be done and analyzed, it's often done by the time I'm done with the left angiogram, at least that of the right. So it identifies the vessels, you pick your frames, and it identifies that for you. And then what it does is essentially takes that angiogram with the noise of the angiogram and everything else and reduces it into very simple structures like this. LAD, what the circuit marginals would look like, the LAD with the diagonals, et cetera. And it automatically identifies the vessels. What it basically allows you to do is just check to be sure that it's identifying the right vessel and the branches. And you don't have to identify every single branch. This is probably one of the biggest user errors I see when people get trained, is that they start drawing every single branch because they can. You don't actually need to do that. You can let the system discern that because it already knows what's most relevant. So it doesn't look at all this. It looks at the ones that are actually going to contribute to pressure loss across the tree. It will extract the vessels from the angiogram and essentially figure this out. And when it does that, that's how it allows it to generate a tree like this, which then feeds into the ability to look at the resistances along the way. It detects the edges, it does the enhancement, it does all this stuff. And you do have to check it. There are times when you can definitely fool it. But by and large, and I've used it very frequently, this happens less and less. And I think someone like Ankit can tell you a little bit more about that, because once you start getting used to it, you know when you shouldn't use it, but then you know for so many cases you actually can. Once it detects the nodes of resistance along the way, it makes a 3D model, and then that's when it starts computing. And so this is just an example of how it automatically detects. I typically go through, check each view, make sure the lesions are right in the right places. You have to select where it is, and then it moves on. It then creates a 3D model of what the resistance would be along the way, analyzes it, and then ultimately comes out with a comprehensive physiologic assessment of everything you see on that side. So for the right, you're going to get the full right, including the branches. And for the left, you'll get the LAD, you'll get the circ, you can get branches as well based upon its analysis. And so my last slide is this one, and Alan Greenspan has this quote, "The process of innovation is of course never ending." So what I'm talking about today is a system I have in our cath lab. But what cool thing about software is that it rapidly iterates and can change literally every few months or so. Now, you don't want too many changes, like that's why Apple doesn't update our iOS so frequently, but everybody typically when the new iOS comes out, you wait a little bit to make sure it's not going to break your phone, and then everybody installs it. And there's certain things you love about it, there's certain things you don't, but the good news in this case is actually there's a feedback mechanism whereby things change. And so when we first started using this, the AI stuff really wasn't there. We had to draw everything. A lot of the cool features that you may see in the presentations today, like turning lesions on and off, addressing that issue of tandem lesions, which is the most common thing that everybody asks, how do you discern tandem lesions? Well, you can do it now. You can just turn the lesions on and off and then predict what your post-physiology is. And further areas of expansion or post-PCI physiology, microvascular or beyond, but it's pretty cool technology, and I think it solves the fundamental problem that we have with wires, which are just that nobody wants to use them. So thanks so much for listening.
So I think we have a few minutes for discussion before we go to the next couple of talks. So we're talking about methodology and workflow and evolution of methodology. So Bill, you've been in this from the very beginning. I mean, you were the PI of FAST FFR. And you're the father, one of the fathers of wire-based physiology. So characterize for us how you put this in perspective in terms of the evolution of doing workflow-driven. I don't want to say simplified because that's the wrong word, but more user-friendly physiology as part of routine PCI.
Yeah, thanks, Marty. I think streamline may be a good term because this really streamlines your workflow. So, historically, before we had this available to us, after we did a diagnostic angiogram, we'd ask for the guide catheter, we'd give some more heparin, nitrates, bring up our wire, equalize, blah, blah, blah. The steps. It takes a little while. and that would just give us one vessel. Then if we had to do another vessel, or if we wanted to do serial lesions, it gets even more complicated. And so now I think what's really nice is that you can train your technician or your nurse or whomever is in the cath lab with you, so that while you're shooting the left coronary, or after you've shot the left coronary and you're getting ready to do the right coronary, they can be running the intermediate LAD lesion. So by the time you're done with your right coronary, you have the answer already, what needs to be done. And then you can go on and assess the right coronary. And so I think that really has been a huge game changer. And then, like I said, if there's two vessels, it really speeds it up. Like if the LAD and the circ are involved, or if you have serial lesions. And I think we'll probably see some cases of how it really simplifies or streamlines workflow in that setting.
It's interesting. While I've been here at TCT, I had a patient who I sent to the left main. It was an osteo-LAD. I sent to the left main to the LAD about 3 months ago, and got readmitted with chest pain. The referring tried to manage as an outpatient and then came in. And I, of course, was like, I must have missed something. There must have been something wrong. The stent was totally fine. And our colleague, Mike Collins, did the case just yesterday, Friday. And essentially, he came back to me, and he's sort of a senior physician, probably not an early adopter of a lot of things. He came back to me and said, the stent's fine, and by the way, the FFR in the ramus, the LAD, and the circ are these three numbers by angio-FFR. And I was like, that's amazing. A, he used it, but B, that would have been a real pain in the butt for him to do 3-vessel physiology with FFR and all those three things, and he just did it. And there was a stent there, left main stent, and obviously the patient's going home and reassured.
Alan, yes.
If
I mean,
I can
Alan
make-
is an aficionado. I mean, he runs our physiology lab at CRF, and he's a stickler. So I'd be interested just to get your impression of this version of physiology in terms of, are there any compromises? And yeah.
Thanks, Marty. What I wanted to mention actually is that it goes far beyond just getting a number. So far we only discussed, is it abnormal? Is it normal? Should we treat, not treat, get a number? I really believe that we should be using physiology to plan the procedure, to understand what we're treating, what we're not treating, to check the results afterwards. So to really incorporate it more into procedural planning and checking the results. And I think this software in particular, the new version, and I'm going to show some of the slides in my talk, allows us to basically do that. And it's far beyond just getting a number. It's really coming down to very, very precise procedural planning and then confirming that you have good outcomes.
If I could add to that, I think the other element that I've noticed incorporating it in our lab is that it sort of democratized the communication between the interventionalist and the staff. So, often we're asking for equipment, give me this guide, give me this wire, et cetera. But now the technician in the control room for our lab is able to guide me and say, hey, listen, I know these were the angles you took, but this is a better angle to see the bifurcation. This is the length that I'm thinking. This is the size. And that's really changed the way the culture of the lab has been. I don't know if you've noticed similar things.
Yeah, I mean, I think honestly, empowering staff to sort of function as the team really unloads us. There's a whole psychology of intervention, or just psychology of how many things you can keep in your head at the same time, and the number is 7. And so if you can outsource some of those things to other people, then you don't have to do it all yourself. And so that's just like Bill talked about, somebody running the analysis while you're doing everything else. You don't have to think about it. They just do it, and then you come and check it and verify it. Don't just listen to the number, but actually verify it. But it's great because it can happen in parallel to everything else you're doing, which in lab time is very serial.
Yeah, and I think Ankit highlights another feature that we maybe glossed over, this three-dimensional reconstruction that you get. So not only are you getting the physiology, but you're also getting some really good anatomic information with respect to where side branches and their location with respect to the lesion, and it gives you a lot of procedural guidance beyond just whether you need to treat or not.
But it's no small thing to suggest that this system helps to teach you to do better angiography. It kind of forces you to be a little bit more disciplined. And as Ankit said, I mean, it's really interesting. It helps you to do better PCI because now you're selecting the best views in order to be able to see the lesion. So there are other kind of secondary gains that are interesting.
Yeah, Ajay, maybe you could comment on, how different are the angles that we're taking in order to use the system?
For me, it's our standard angles. It's just because I've always been taught. I was taught, Alan and I were taught like sticklers and how to do angiography, and so
orthogonal views was nothing new. I think the only thing that we probably adapted for some of our operators was they take it maybe one less mag with less panning. So on a Philips system, if you're used to 27, I don't usually use 22, you maybe 27 or 31, depending on where the heart is. But it makes you better. Also, honestly, for like CTO intervention, that's how you take the images anyway, because you don't want to pan, you want to stay on and see where the collaterals are. So that's the only adaptation that's been taken. It's probably for the good.
I think so too. Irrespective of the system, I changed my practice completely, but to the no panning, and it really, I feel, changed the way I look at things, diagnose things. So irrespective of whether one would use this or not, I think this is now maybe the right way of doing it.
One element that I think is really neat is a kind of an analogy to like structural heart and TAVR. In the last 10 years, we wouldn't imagine putting a valve in without having, sizing data and so forth, sort of virtually doing the procedure. And in cath, we routinely put a stent in and then try to figure out what optimization we need to do. But here, you're able to do a lot of modeling before you do the implantation. And I think it really has changed the way, whether you go shorter or longer based on the curve, and you're able to hypothesize, okay, this is what my outcome should be, and then confirm it very easily.
So we're going to talk a little bit about the nitty-gritty. I don't want to get too much into detail. I think we had an overview so far about how you use it in practice, a little bit what the data is. But let's talk a little bit more in detail about how the system works. All right, these are my disclosures. So one of the things that I cannot overemphasize, and for those of you who attended the late-breaking session just a minute ago, talking about DCB and that not all DCB is the same is true for angiographically derived physiology. So you see, these are basically the systems that are available. And I don't want to go into too much detail, but the bottom line is that the technology used, the computations used, the angios required, all of that is different for each of the individual systems. And so just because one system works or one system does not work, it doesn't mean you can apply the data to the other systems. And so we looked at this before. This is FFRangio, and we kind of built this 3D resistance model. And the idea of this is, as you see basically in this representation, as you're taking the different angles, you develop more clarity, because sometimes the view isn't perfect. And so the three views are critical for the system. And then you're going to have this resistance model, which kind of is almost like an electrical circuit. And you have these resistors kind of back to back that kind of build this model. And so that's kind of the basic idea of FFRangio compared to the other models, which mostly rely on computational fluid dynamics and basically on the Navier-Stokes and the Bernoulli equations. And when you're looking at these equations, what you can see is that there is a lot of input of data. And so if one of these parameters is off, and then you square it, which some of them you have to do, you can basically introduce an error very, very quickly. And so that's why I was saying these systems are not the same and have to be looked at kind of from a different angle. And so the advantage of having, these three images is to basically avoid some of the overlap, foreshortening, some of the angiographic limitations that we see. The other basic principle of physiology that I think is very, very important is to understand the relationship between the percent stenosis and how much myocardium is supplied by the vessel. That's really key, because if that wasn't the case, we wouldn't have to do physiology. So you can have a 50% stenosis of a proximal AD, which might be significant by physiology because it's a huge territory versus, I don't know, an 80 or 90% stenosis of a small diag, which it might not be. And so it's really critical to take that into consideration, which, as you see here, is incorporated into the measurement and into the actual calculation. This is the evolution of the system. We talked a bit about, back in the old days, you had to do a lot of manual input, which now has changed. And of course, also the whole device and the console is much more slick compared to how it used to be. You have options now to have it either outside, you have it on the boom, or you can have a small cart that comes into the room. Either way, it basically gives you the same information. And so this is how it looks like when you actually do it. One of the things that is important as well is that when you're looking at the absolute number, like we talked about, what is the FFR in the distal vessel, it's not all the way in the distal vessel. Because for some of you who do CT FFR, it's basically almost always abnormal in the distal LAD because it's just so far down. So in this case, it looks at the value 80% downstream, so not all the way at the apical LAD. And then importantly, you have this little arrow that you can move along the vessel, and it shows you the computed FFR value at any point across that line. This, I think, is what I've talked about before, is really, really critical to understand the pressure loss that is associated with each individual stenosis. And this allows you to really plan your case, because it's not good enough really these days to know, oh, there's an abnormal FFR in the LAD, and then the rest you do by the angiogram. The whole point of using physiology is to understand which of these lesions is contributing the most to the pressure loss. And I think you have this, very elegant tool that not only allows you to understand it, you can actually manipulate it and play with it a little bit. And you see these little tabs at the bottom. And so what these tabs are doing is they allow you to eliminate the stenosis theoretically. It's basically you put a stent in theory, and it allows you to compute the FFR when that lesion is eliminated. And so when you have tandem lesions, like in this case, you can activate, one of these buttons or both, looking at these individually to understand what is my post FFR going to be and how much treatment does it require to kind of get back to a more or less normal level. The other tools, interactive tools that are available, is the sizing tool. This has been validated also, especially for the length of the measurements, so you can use that very accurately to determine how long of a stent you need. There is some good data also on the diameter compared with intravascular ultrasound. There is a factor you have to kind of apply, 1.25, so you have to kind of upsize a little bit, but it's also a reasonably good correlation between the two. And then finally, you can take this home, show your kids, but more importantly, show your referring doctor, show the patient. All of that is available on your phone. And then finally, I want to talk a minute about the post-PCI assessment, which is actually a new feature in the system. And I think equally important, because you want to make sure you check your work. And we have done a lot of work on looking at post-PCI FFR or physiology in general, indicating your long-term outcome. And so this is how you would basically look at this afterwards. It's very, very quick. The system actually helps you select the images post-PCI, and immediately within a few minutes you have basically an answer: did you do a good job or not? What is the physiology afterwards? In this case, obviously, it's a very, very nice result. And then finally, you kind of have this diagnostic tool that you can print out, put in this chart, or give the patient, where you have the images and the physiology before and afterwards as a report card, if you will, to kind of file. And so this has been actually is presented at TCT this year in a 200-patient study. And not only that, there is a number of things ongoing with FFRangio at this meeting, as well as ongoing and future studies, which we're going to talk about in the upcoming discussion. Thank you so much.
So thank you. It's a bit humbling to be here with my co-faculty, and I'm really reflecting on my sort of journey of how I, as a self-professed physiology nerd, how did I go from being an attendee to the conference to being here? And these are my disclosures. So it all really began in 2022 when I was attending TCT, and Brian Burkhart from Medtronic, who works with us locally, realized my interests, and in the Medtronic booth, there was a CathWorks display, and he's like, listen, I think you really would like this. This is something interesting. It's kind of, stuff that you really get excited about. And so as I learned about the technology, I got super excited. And then I had to come up with the value proposition for my two hospitals that I go to, very different ownership structures, to really provide the value proposition. Why is this an additional technology that we should bring on? And I think this has been explained very nicely by my co-faculty. So then once we got it, it was really a key of how to implement it. And the first part was a psychological one, right? We all live in our comfort zones, and to get to become uncomfortable with the uncertainties of a new technology, learning how to trace, knowing what kind of cases are appropriate or not. You really have to be able to get into the fear zone, the learning zone, and then really the growth zone. We were able to attend the super user program and met another physiology guru, Dr. Kern. But this was the first time my team was able to move out of New Jersey and go to California and really work with peers and really see how great of a job they're doing. And what we did was we decided that we were going to have every one of our cath lab staff techs become super users so that we would be independent of whether or not a rep from CathWorks or Medtronic was available, and we could do these cases 7 days a week, morning or night. Interestingly, we were able to involve our APPs and other cardiology team members that are involved in the care of these patients. So when they're reading reports, they're understanding what the data means and how it's going to incorporate into a stage procedure. So this is Mario teaching Amanda, one of our nurse practitioners. And to really show the scalability, we started with our first case in May 14th, a year ago. 3 months later, we're at the super user training, and I was able to attend as an attendee, which was really a great experience as a physician to see how the super users are being trained. And by October, a year ago, we did our 100th case. And really, we've had a consistent growth in our program where just about a week and a half ago, we did our 400th case. And this is at a small community hospital in New Jersey in a very populated area with other cath labs. So physiology and the ability to incorporate it is present in all of our labs. So how does our cath lab workflow really work out? So we're a CT first program. We do a lot of coronary CTA. So we have anatomy and physiology already up front before the patient comes into the cath lab. However, there are patients that show up from the emergency room or other referring providers that don't have that data. In that case, we'll do wire-based therapies. The need that we had was the multi-vessel, the multi-lesion, the complexity, and the fact that, appropriate use criteria, and as a cath lab director, we had these niches where we weren't getting all of the data. And I had to make it easier for my colleagues, some of whom are working at other health systems, to adopt the technology very easily. And I had to make it very user-friendly. So if the staff can provide the data on their need, it would really improve our workflow. And then continue to incorporate this into our imaging modality. So I just want to use 2 examples of cases. And this is an earlier case. A 76-year-old came in with a non-ST elevation MI with chest pain. So we do the diagnostic cath, and you can see that there's a high-grade lesion in the circumflex. But what's important to recognize is also there's moderate disease in the LAD, and the right has this tortuous loop with disease. Is this a patient that we should send for a bypass evaluation? Is this a person we stent? What are we trying to do? And historically, this would be a challenging kind of ad hoc kind of decision-making. So with FFRangio, we're able to quickly run the LAD, and we see that it's 0.76 and really a focal lesion. We run the right, and we see that it's not physiologically significant, but there is disease there. And then the next question we're able to do, because now we've already paid for the card, right, is in 2025, can we use AI to help with procedural planning? This is a bifurcation lesion. Do we do provisional stenting, 2 stent? What's the vessel size, lesion prep? What are the things that we can incorporate? So quickly, we're able to process the circumflex. We know that it's going to be significant, but we're able to now see what the pressure pullback curve looks like. We're able to see with lesion impact whether or not we're going to make a good post-PCI assessment. We're able to use the sizing tool to size the stent and get an approximation of the length that we're going to need to do. And then complete our intervention with IVUS guidance and get a good result. We can confirm the post-PCI result, and so we see the physiology is good. But as you'll all note, the OM looks pinched, right? And this is a clinical scenario that we often confront. So here, by just tracing the OM, we can get another data point that confirms that, hey, we don't need to do anything. We can just watch this in the patient who's asymptomatic. So let's go to a little bit more of a challenging case. So it's a 48-year-old gentleman who comes in with typical angina. He's got the risk factors, but the most concerning part is his family history. Both his sister and brother are deceased from MIs in their 40s. So we do a coronary CTA. The report reads a moderate lesion in the proximal LAD of non-calcified plaque. And we do the FFR, and we see that the FFR is 0.81, so just about the cutoff. It's in the gray zone. We do the diagnostic cath, and when we look at the angiography, we see that the LAD doesn't look impressive. So we have a CT that's abnormal, coronary angiogram that's mild. Well, what do? We have a patient that's symptomatic. Well, we're a physiology lab, so we're looking for microvascular dysfunction. So we go ahead and put a wire down and do the microvascular assessment. Now, while we're doing this, we can get an RFR and an FFR. So we get an RFR, which is abnormal, and an FFR that's borderline. So we're still kind of in a conundrum. And the microvascular status shows a borderline CFR, a high IMR, and an RR that's normal. So there is some microvascular dysfunction. But the part that bothers us is the gut sense that this is a guy with a terrible family history. The CT is telling me anatomically there's something there, but I can't find it. So we decided to run CathWorks because we've become very familiar with looking at that pressure pullback curve and the numbers, right? And there's so much more to just the FFR value. So when we look at this case, we can see that on the pressure pullback, there's a focal lesion. So we can see that there's a steep pressure pullback curve. And on the impact curve, the pie chart, 40% of the myocardium that this is demonstrating is ischemic with an FFR less than 0.8. So now we go ahead and do intravascular imaging. We confirm that there is a significant severe lesion. Go ahead with IVUS-guided PCI. And the question that we look at in this sort of case, and I don't think these cases are infrequent of patients that are coming to the lab that have significant histories. When we look at the post-PCI data, we see that the post-FFR at the level of the stent is 0.87, so we've got a good result. But what's interesting is the apical value is still 0.79. This is consistent with the distal diffuse disease. But what the pie chart really is able to help us see is that we made a significant impact on the ischemic myocardium. We went to 40% to less than 5%. And at 6 weeks, the patient has remained asymptomatic. Now, to summarize this case, this is a case where we did a CT FFR, we did a cardiac cath, we had to do invasive physiology assessment, we did microvascular assessment, we did FFRangio to get to an answer, and we did intracoronary imaging to validate what we were seeing and to size our technology. And really the question is, can we do all of this in one tool with one technology rather than needing to do all of these additional steps? So, thank you.
So what does the panel think of the next steps for this technology? Do we just sit back and wait for all rise? I mean, how do you integrate it now into your current daily workflow doing PCI? So let's start with Ankit.
Yeah, I think, for our lab, we're using it routinely because I think we're able to get multi-vessel analysis, and as a CT first, even if we see other areas, we're able to incorporate it. For post-PCI, I think we're going to get increasing data that post-PCI physiology is going to be a very important marker of residual angina and outcomes of stents. And the more you use the technology, the more you see these other benefits of sizing, length, procedural planning. So I find it very helpful in that element.
So routine systematic use for the majority of PCIs?
Yes, that would be my...
With the major additional advantages that you get for multi-vessel disease, for branch vessel disease, and certainly doing the post-PCI FFR, this is an easier workflow-driven.
And when you use the technology, it's like a wire. You purchase it once, you're able to do as many analyses as you need. So you're able to give a much more comprehensive result, much like a CT FFR, where you're able to get the data on multiple vessels.
Yeah, I think for routine cases, we clearly have enough data for routine use. I'd like to see more data in some of these select groups, left main or side branch, things like that, to post-PCI to demonstrate effectiveness in those settings too. Not to get too into the weeds, but I think one of the advantages that Alan mentioned was the serial lesion assessment. And when you're doing FFR, there can be crosstalk between lesions, and so that requires you fix one and then you reassess with adenosine again to check the other one. The system can account for all that up front and give you that information. And the post-PCI, just to clarify, you don't need to repeat all 3 images. You can use one of the images that had the lesion in it pre-PCI and then just subtract the lesion out, and it just needs the 2, and you can have the wire still in the vessel also. So there's a lot of safety precautions, I guess, to allow you to do that.
One of my pet peeves in the cath lab in general is that I feel we have just too much clutter everywhere. The table is full with all these controls. We have a million different systems, imaging, physiology, whatever it is. Sometimes I ask myself, where should I stand? I have no room at the table. And so how I see the future of a technology like this, which I think we all agree is very, very useful, in basically systematically assessing every single patient, because of all the information that we can learn, is to fully integrate this into into the lab, that basically every patient having an angio, this will automatically come up. And obviously it will take a little time for AI, et cetera, to kind of build that model. But literally, as you shoot your angio, you can get maybe these calculations in more or less real time with minimal or ideally no input at all. And so maybe in 3 to 5 years, we are at that stage. And I think once we are, it would really change the, how we practice interventional cardiology in this country, which we all know there's a huge variety in how practice occurs.
I think one thing that people are going to get jealous here is that we don't actually, in our lab, have a system where we have to pay for it every time we use it. We had a certain level of usage, and we essentially have a subscription model, which allows us to use it however many times we want to, because it's predicated on the fact that we're going to use it X number of times. And so, honestly, that allows things like what Alan is going to talk about. The other thing that I would say that maybe is a little provocative, but I think is important, is we're very hopeful that an all-rise will show that it's as good as a wire, and then adoption can go up. But the wire is not infallible either. And I think everybody here who's done wire-based physiology, could raise your hand if you've done wire-based physiology of the circumflex and gotten a value that's greater than 1. Like, it happens routinely. And because there are basically the height of the circumflex is different than the height of the aorta. And the same thing is true for the LAD. In the LAD, it's more often positive. And just because the studies that have been done with FFR wires have used that as the gold standard, the 0.8 cutoff, without adjusting for these heights, doesn't mean that's actually right based on the angiogram. And so it may be, in fact, that if you look angiographically and model the resistance and don't have that confounding factor of the height of the transducer relative to where the vessel is, that the angio FFR might be a truer value for what's actually happening than the wire. So let's see what the results show. I think it's a very fascinating area, but the way we think about gold standards might actually change over time, because let's face it, the way the wire was validated was on the basis of a relatively small number of stress tests, which is not even the best test to look for ischemia.
Yeah, and another area I think where this system really has great application and we need more data, I think, are the ACS patients. Physiology is, grossly underutilized in that scenario, and we don't even know for sure about its, utility and safety. I think this system, particularly in STEMI with multivessel disease, where kind of the last thing you want to do at 2 a.m. is have to go wire a non-culprit vessel to assess it. This is really going to, I think, be a game changer in that setting.
So is that one of the next studies that you'd be looking at acute coronary syndromes?
That's my hope.
And to be honest with you, there are people don't always know this, but there are studies like the FIRE study, which was done in Europe, that used angiographically based FFR as a component for assessing non-culprit disease. And that's not a widely promulgated fact. It's true.
How do you think that FFR angio is going to change the use of intravascular imaging? So Alan, you do your PCIs, so everything is OCT guided, or not everything, but a lot of it is. Using this systematically, would it change your thinking in terms of?
I think both are complementary. I don't think that you should use one or the other. We do basically more or less 100% imaging guided PCI, but that doesn't mean we don't do physiology. There's now different ways of doing physiology, angio-FFR being one of them, obviously the wire-based, but now we also have imaging-based physiology. And so, you can use any one or, a combination of, but I don't think that one should think about it as, different entities.
Yeah, I think the intravascular imaging is always going to be key for optimizing your stent, but this post-PCI angio-based will really facilitate looking for, issues outside of the stent that may not be recognized immediately just looking at the angiogram.
And I think the fact that, for the last 10 years, we haven't seen a significant rise in intracoronary image use. I think it's up to 30% now in the US. We have to have these other modalities to help facilitate it, right? On the sizing tool, you're able to get additional information that could help an operator who who's just not an image guided PCI person to at least have that additional piece of information. Same way the imaging tools are allowing physiology to be incorporated.
You can use information in a complementary fashion. So if you have diffuse disease, for instance, everybody knows if you put an IVUS catheter down and you see disease everywhere, you're going to end up with 80 millimeters of stent. So you can use the IVUS to determine what your prep modality is going to be. Is it severe calcium? You know, where the MSA is, but why not use the complementary physiology to dictate where you're going to put the stent and what areas you don't have to stent, because there's plaque, but it's not imminently significant. So using both of those things, it's not so dichotomous to say we use physiology to diagnose and we use imaging to treat. We could use both to do both as long as we're very clear as to what the question we're asking of the individual technology.
And to add to that, and maybe a bit controversial at this point, but looking at the pressure loss from a stenosis, I think is very, very important, and sometimes, honestly, could potentially drive PCI even in the absence of overall, ischemia in the vessel. In a sense that, let's say your FFR is 0.82, but you have a significant pressure loss in one area, let's say in the LAD. I think there's good reasons, to potentially, look at that carefully and say, well, maybe the patient would benefit from PCI, because of the whole vulnerable plaque story and plaque burden and again pressure loss in a stenosis.
And then just one final question. This post PCI FFR has always intrigued me, and it's going to be interesting to see where that plays out. But I can imagine that this would be a very powerful tool for that setting. Are you using it on key systematically post PCI?
Yeah, so I think this is a great secondary benefit of incorporating CathWorks in, because we trace the tracings and we can do it relatively easy post. We do it 100% of our CathWorks cases because it's so easy to do. And I think from a researcher perspective, this is the really neat thing. You can imagine how you could rapidly do trials, because it's not a challenging, you're going to put a new wire down and you're going to do a step with a different piece of technology. So I think it should advance the field.
I think the bifurcation lesion you showed was really instructive, though, because people hem and haw and they take views either trying to hide it or views trying to expose it, but yet you can easily resolve the situation, and it's very consistent with the wire-based physiology data. But it's helpful in patients that happen to have residual symptoms afterwards because you have done it, and you can with assurance say, well, we investigated these other branches.
Yeah, I think the post PCI physiology is really, like you said, really intriguing question. Clearly, it's prognostically important. Can we modify outcomes by acting on it? I mean, I think we'll wait for Alan's study to find GPS to help guide us in that regard. But we should be able to, like Ankit said, with FFRangio, do a lot more studies very easily.
Well, great. Just want to thank everybody for their attention. I know it's a long day, and you're still in the middle of, basically day 1.5 of TCT. Thank you for coming, and we'll hang around for a while if you have any further questions. But I think this was a good example of how a deep dive into a particular technology gives everybody more insight. Just discussing some of the, current state and future directions of some of these new novel modalities is extremely valuable, and one of the things that we try to do more systematically at TCT. So thanks to the panel, thank you all, and again, thanks for CathWorks for supporting these kinds of educational efforts.